Welcome everyone. My name is Tibor. I'm a clinical psychologist, and I would like to move to a different topic, to a different discipline, if you may. My topic is investigating the bidirectional relationship between pancreatitis and psychological conditions. I work at the Institute for Pancreatic Disease at the Semmelweis University, and my vision in this game would be patient care where GI problems would be better prevented, mitigated, and cured by a psychosocial medicine. And my mission in this project would be the development of psychosocial interventions and prevention programs. But in order to do that, we have to have specific goals. My first one that I'd like to present first is investigating the prevalence of anxiety and depression in patients with pancreatitis. And then I would like to move on to the second one, which is the risk factor project. So the first is a systematic review and a meta-analysis that we started in September last year. What do we know? Where is the current frontier of our knowledge? We do know that there is, as I mentioned before, a bidirectional relationship between the brain, the gut, the microbiome, and these different psychological variables. We already know that. We also know that depression, for example, increases the risk of chronic diseases, and the other way around as well. We know that chronic diseases increase the risk of depression, for example. But then what is it that we do not know? We don't know the exact number for pancreatitis, for acute or chronic pancreatitis. So the problem would be that if the psychological needs are not investigated properly in AP, they would result in worse clinical outcomes. So our aim would be, of course, to first explore the prevalence of these aforementioned conditions. In order to do that, we formulated the clinical question as follows. What is the prevalence of anxiety and depression in patients with pancreatitis, resulting in a COCO-POP framework? And of course, our hypothesis was that there is a high prevalence of anxiety and depression in these patients, given our clinical experience. This of course, moved on to a systematic review done in Medline and Bayes Central, and it resulted in 101 studies that we needed to go through in order to investigate. We finished the prevalences, the smoking-related data affecting the manifestation of pancreatitis and the aforementioned prevalences. We worked on the etiology data and the questionnaire scores, and we will move on to the citation chaser at this point. But first, let's have a look at the preliminary data. If you look at these tables, we see that there is a considerable percentage. In one case, it's 15%, in the other one, it's 35%. This is for only anxiety. If we also incorporate into the picture the question of depression, as I mentioned before, then almost the same numbers appear, 16% and 34%. Now, of course, there are some limitations. These numbers have to take into consideration with quite a bit of limitation in this case, given the high heterogeneity of these studies. Also, there were huge differences between how they defined their clinical outcomes. And also, most of them were retrospective designs, and hardly any of them had any follow-ups. And of course, the strength is also that the assessment of these specific psychological constructs do influence these pancreatitic clinical outcomes, but also we have to take these with a grain of salt given the limitations I mentioned before. So the conclusion is the following. There is a considerable prevalence of anxiety and depression with patients with pancreatitis, and this result could be translated into two different areas. One of them would be for practice. Of course, there is a need for the revision of the guidelines, because psychologists do need to be incorporated into these wards. It's not enough to just call psychologists when they are needed. Testing and monitoring is needed. Psychologists need to be working on these wards simultaneously with doctors and other disciplines. And also there's an implication for research. There's a dire need for prospective and intervention studies in GI psychology. So we are done with the data extraction, and we move on to the other milestones in the upcoming months. And as I mentioned before, we need to move on to risk factors. If we know the prevalences, we have to know what risk factors do we have to deal with in our clinical practice. Three clinical questions come to mind. The first one is, what is the dynamic change of psychological variables during the acute phase? Again, let's go into the background. What do we know so far? We know that psychological experience could be described as having this feeling of unpredictability. These patients also experience feelings of varying degrees of stress and social support. And for anxiety, there's no significant change for the first 7 days of hospitalization, whereas for depression, what we see is that first it increases and then it decreases. So the aim in the second project would be explore this dynamic change of these psychological variables during the acute phase. This would require a PECO framework with a prospective observational design as we move on. Now, for the second clinical question, we formulated it as the following. What are the risk factors leading to worse psychological assessment scores in AP? In order to illustrate the importance of this question, I brought some data from our ward, the etiological risk factors and associated depression and anxiety scores. If we look at this table, we see that if we examine these at admission, right after the patients are admitted to the hospital, if they have alcoholic etiology, they are already on the verge of subclinical or borderline abnormal psychological alteration concerning anxiety. Now, this is clinically relevant because it says that these patients need to be identified at admission and then followed throughout the hospitalization. So possible risk factors could include, for example, underlying mental disorders, psychiatric indicators like emotional lability, and other stress moderators when the patients are admitted. And a possible solution would be, if we end this project in the future, finding the most vulnerable patient population at admission and then provide psychological care for them. Aim, of course, would be the exploration of these risk factors. Now, this would result in a PFO framework with the hypothesis that psychosocial factors, for example, smoking, alcohol, income, etc., contribute to the aforementioned high levels of anxiety and stress in patients with AP. And this brings us to the third question, finally. How do psychological assessment scores influence the clinical outcomes of acute pancreatitis? The very somatic things that you were talking about before me. And this is where our disciplines meet. This is where we get truly multidisciplinary. Again, just a little bit of background for this question. We already know that the problem for many disorders is that mental disorders elevate the risk of adverse clinical outcomes. If you look at this data, for example, there's a clear linear connection between the prevalence of depressive disorders and, on the other hand, the attributable risk of heart failure. Again, in the other research question, we do not have the same data for pancreatitis. So we need to move on. We need first to produce these numbers. Our aim would be the investigation of these psychological alterations and how they affect the clinical outcomes of AP. This, again, would result in a PFO framework with the hypothesis that unfavorable psychological assessment scores could worsen the clinical outcomes of AP. Again, some preliminary data from our ward, we clearly see that as the severity of the psychological assessment scores go up, so do the severity of AP according to Atlanta classification. As a summary, these are the two projects that we are working about, and I would like to conclude my presentation with the eternal quote of Ralph Waldo Emerson: please do not forget that the first wealth is health. Thank you for your attention.
Thank you, Tibor. The floor is open for questions.
This is very interesting. And, you know, alcohol is the best anxiolytic. And what is the connection between the highest anxiety score? Are these patients probably at the verge of alcohol withdrawal or something? Or is that all that serious? Or how do you assess the anxiety in these patients? And how do you differentiate which are at the highest risk for further treatment or prevention at the during the course of the treatment? Yep.
Well, we need to follow a step-by-step approach here, because not everyone who has anxiety-related symptomatology develops anxiety disorder per se. So what we do is that first we use a questionnaire where the cutoff point is around 8. So if these patients reach this number, then we go forward. That's why the step-up approach. And then if we arrive at the last stage, we have to call for a psychiatrist. But if their severity is not an anxiety disorder per per se, but just some anxiety-related symptomatology, then clinical psychological intervention is needed. And also, it's important to note that it's not just a withdrawal, because there is a hypothesis in clinical psychology and addictology that one of the reasons of alcoholic problems per se is an underlying anxiety-related disorder. So all things are interconnected. It's not just a one-way street in this case. Thank you for your question.
So I would have a question regarding your first project. When you showed the plots, that was based on wasn't based on multivariable analysis. Am I right?
No, these are just the prevalence dates. So that's why I said these are just preliminary data. And now we've done the assessment scores extraction as well, and hopefully we will present it at the next progress report.
And would there be some chance to have the results adjusted for the confounders like alcoholic use disorder, etc.?
Yeah, that's the case. And for example, when we are talking about subgroup analysis, it's also important to have a look at this data from this respect as well. We focused on smoking first, but there might be other subgroups that will arouse as the analysis will go on.
Thank you.
Thank you.
Are you aware of any studies in the context of pancreatitis or any other acute disease where unintentional but harmful psychological intervention from unskilled and untrained personnel providers, healthcare providers, affects the outcome? I give you an example. A nurse telling you off that you have shitted in your pant again, and making you feel bad. Things like that. Unintentional but harmful psychological interventions.
Well, the problem is that I can only provide low quality evidence in this respect. Expert opinion and some studies from China, which are more qualitative in this regard, so interview data and so forth and so forth. The clear problem is that these are not necessarily psychological interventions. They have to be clinical psychological assessments and interventions. And the difference is that when we say that, yes, this patient needs psychological help, we always think that, well, this is what psychologists were trained for throughout their 5 years. It's wrong. Clinical psychology is an extra training, like the extra training that doctors go through. So it's very important to note the question of proficiency in this case, and also of clear professional help. So it's not enough to have a nurse. It's not enough to have a physician go to the patients and try to convince them to change their health behavior and so forth. All these studies that we analyzed in this respect have proper psychological care in this respect for this very reason, because if we don't give this care to our patients, but we try to approach this from a more moralizing perspective, we don't have good clinical results.
Should healthcare providers be measured against some kind of norm in terms of their potential for psychological impact, negative or positive? Because I truly believe that the doctors and nurses and any healthcare providers around the patient, especially in an inpatient setting, they psychologically intervene.
Mm-hmm. Again, I would like to use the word step-up approach here, because there are some patients who are not in the clinical population, not even in the subclinical population, but sometimes they do approach their doctors or psychologists with a problem like this. It's perfectly fine to have a doctor create an empathic sort of relating to that patient. But again, are there any trainings? Is it included in the doctor's training? So I would argue that if psychologists are included in these wards, it's not only for the patients, but also for a sort of socializing effect for all of their colleagues who work with patients.